Hey, good evening, everyone, and namaste. We're very excited to present you an enriching talk on clinical grade NGS. Next slide, Mayank. Uh, at Max Saket, which is a leap in infectious disease diagnostics. We have the honor of presenting this particular talk by a path-breaking veteran microbiologist, Dr. Bansidhar. Before we speak about Sir, I would just like to speak about my company, Haystack Analytics. We are a health tech company based from IIT Mumbai, and we are on a mission to bring genomics to the forefront of diagnostics and healthcare. And our work has been recognized by the Prime Minister of India and various organizations like SIGN, IIT, and these are our partners, Intel and GE, and our other partners, our chief partner, who is going to be another speaker today, that is Dr. Bansidhar from Max Saket. So today our chief guest speaker is Dr. Bansidhar Tarai, and I will be moderating from on behalf of Haystack Analytics. I am Dr. Shamili, and Dr. Bansidhar is a veteran microbiologist. He has been the director of microbiology and infection control at Max Saket Super Specialty Hospital, and he coordinates microbiology and infection control services across the Max group of hospitals. He has had over 19 years of experience. He's In the last quarter, he has added 5 international publications. He has authored over 94 publications, 6 books, chapters. He holds an MD degree from the prestigious PGI Chandigarh, and he is a proactive antibiotic steward, and he has been in the pioneer policy of antibiotic policy of Max hospitals and plays a very important role. He has been the recipient of multiple awards in infection control, patient safety, including IPSC and ABP News Awards and Max Healthcare Susruta Award. And he has also served as the member of Hospital Infection Control Society of India, ICMR, AMR, Antimicrobial Resistance HAI Network, and CHAM, which is now called ESHAM, which is International Society of Human and Animal Micrology. And he has served as the executive member in the committee into 2021. He's also someone who is into a lot of accreditation and quality promotion activities, and he has been the lead technical assessor for NABL and NABH entry level. So this particular session, Sir is going to enlighten us on his uh, wonderful journey with infection and NGS-based ID diagnostic tests. And over to you, Sir. And dear participants, please reserve your questions towards the end of the session. Over to you, Sir. Thank you.
So thank you, Dr. Samli, and thank you, Hashtag Analytics, for the innovation, the new innovation of NGS, that is nanoper sequencing. So in between, I'll make the video switch off, but whenever you want, I can you can stop me, also ask the questions in between. Also, there is not a problem, and we'll have a more discussion, or we can have a questions at the end. I hope I am audible to everyone. So now let's talk about NGS, or nanoper sequencing in the infectious disease. So NGS has been in a core diagnostic for oncology, marker, genetics things, but for infectious disease, there are a lot of debate on this. But now the most important challenges in NGS is that quick turnaround time. For normal NGS, like the sequencing by Thermo Fisher or some other, it is the turnaround time is almost 1 week, 2 weeks time. I think the only solution is the nanoper sequencing, which we have started. I think Hashtag is the first company in India who started this nanoper sequencing for infectious disease. And we have started in the last, I think, 1.5 months back, or 2 months maximum, 1.5 months back. And we found so many important organisms, clinical cases, which I'll discuss to you. And the most important things, we are able to give the TAT in 24 to 48 hours. So if you see 10 years before, there are only few things are available for diagnosis of infectious disease, like the cultures or some of the molecular techniques. But then gradually the biofire came where it can detect many things. But the disadvantage is that only few panels are there, like meningitis panel, pneumonia, upper respiratory, GI, and then joint infection panels. But problem is that we have many samples from the peritoneal fluid, blood, sepsis, long tissues, or even deep-seated tissues, or even sometimes synovial fluid. So many samples where we're not able to have detect most of the organisms. So now we have to come across the NGS platform. Yeah, it has advantage and some disadvantage also, because we some normal fluoride can pick up, but we have to interpret very carefully. But there are many advantages here. I'll show some of the important cases. We are never able to diagnose endocarditis, which we have diagnosed. We have diagnosed many even brain abscess. Many things we have diagnosed, which is very difficult for to culture or do the PCR. Now, let's start why we want this, the burden of infections. We know there are many infections and many MDR infections, many MDR Klebsiella and Acinetobacters, which is one of the major challenge for us. Gram-negative infections. If you see top 5 organisms, we have Acinetobacter. Top one is Klebsiella, then Acinetobacter, Pseudomonas, Candida auris. These are another infections which cause some of the hospitals is even more dangerous. So infection is there and MDR infection is there. So here the NGS platform, it is not only detecting the organism itself, but also detect the antibiotic resistance genes. So that is really helpful. It is a solution for ID as well as antibiotic resistance genes. Next slide, please. The burden is such that we don't have any antibiotics. And there are so many resistance patterns are coming, and so we need an early diagnosis. And most of the times, the patient had already received antibiotics in some of the hospitals. So sometimes it's very difficult to grow culture. So in that case, molecular remains the main choice. But in molecular, there is many challenges. In PCR from blood is very, very difficult. So only and PCR can detect some organisms, not many. But in sequencing, you will get thousands of organs, 30,000 bacteria, anaerobic bacteria, fungal, viral. So all the things are important. One minute, I'm getting call. So so we have a challenges. So we have to do with the sequencing part. Next slide, please. So need for the hour is comprehensive. We need a detailed organism detections and accurate. And our turnaround time is very important. 24 to 48 hours is the turnaround time. It should be cost effective and it should be sensitive. It should be reproducible. It should be specific and easy to perform. So nanopore is a very cheap, small chip like things, and where you can detect all the organisms very clearly, precise, and in fact golden hour. Mainly the initially 24 to 48 hours is golden hours. Next slide, please. So in the NGS, if you see the developing of NGS, so we have a first generation, we have a second generation, we have a third generation. So first generation, we have a Sanger sequencing, and second generations, like they are mainly the first generations, it detects of around 500 to 1000 base pair fragments. Whereas second generation is is basically 50 to 500 base pair fragments. And whereas the third generation, we are talking about the Oxford nanopore, is the long read sequencing and sequence of DNA in real time with single molecule solutions. So next generation sequencing is massive parallel sequencing, ultra high throughput and scalable. This is basically a third generation sequencing. Next. So there are a lot of papers gaining around of NGS for diagnosis of infectious disease. Here, one paper is rapid next generation sequencing based on diagnosis of bacteria in septic patients. We have a clinical performance of nanopore sequencing for diagnostic of infectious disease. We have a rapid identification of pathogen and antibiotic resistance gene and plasmid from blood cultures by nanopore sequencing. So we have many articles where the sequencing part can detect the organism as well as the resistance genes. We have few multiplex PCR panels where it also detect the PCR as well as the resistance genes. But in nanopore sequencing, it will detect all range of organisms with resistance genes. Next slide, please. So, if you see what is the gold standard is the blood culture, but it is time consuming and poor sensitivity. And prior empirical therapy may confuse the results and will have the sensitivity is very low. So, low clinical sensitivity, especially for fastidious organisms, poor guide to pathogen diagnosis. Similarly, we have a PCR technology, we have ambiguous results and small detection range that can detect only 10, 15, or even 20 organisms maximum, where NGS can detect many organisms. And we have need specific primers. Next slide, please. So then why NGS? It is an open platform. It provides the opportunity to detect bacterial, fungal, viral, all three organisms together. Bacterial may you will also get both aerobic and anaerobic in a single assay. That includes all the difficult organisms and all fastidious organisms, all non-cultural organisms. No need for specific primer design, that is only for PCRs. The clinical sensitivity varies 86% to 92% and specificity is also 78 to 84%. Can directly detect thousands of fragments of single test, thus reduce the number of tests and detection time. Data-driven diagnosis without permanent or suspension species, hypothesis free. So unbiased or untargeted, so benefits from any DNA sequencing information within the patient specimen. Next, please. So more effective, why NGS? It is more effective in detecting co-infections and a good guide to antibiotic therapy because it also gives the antibiotic resistance detections. Not affected by prior antibiotic therapy if a patient is for resistance, can be quantitative through counting the sequence reads and calculation of statistical significance. Recent developments in sequencing techniques like Oxford nanopore and Minion device, it can detect the organism in 24 to 48 hours maximum. Next slide. So if you see nanopore read sequencing, the choice is short read sequencing and long read sequencing. Short reading sequencing is basically targeting some of the 16S variable regions and only ITS1 and ITS2. Whereas long read sequencing, whole 16S and ITS2 can be read at a goal to potential to provide better taxonomy resolutions and species level. Short read sequencing have heavy infrastructure reagents and small footprints of Oxford nanopore enables so basically long read sequencing is more important. And cost and another turnaround time is reduced at the same time with smaller batch of processing feasible. So near a point of care testing for if you see long nanopore sequencing. Yes, please. So we have Max Healthcare launched NGS, I think 1 or 2 months back, and we have done many samples. I'll tell you about some of the case studies. So next slide. So these are some of the publications. Is an integrated method of targeted Oxford nanopore sequencing and an automated bioinformatics for the simultaneous detection of bacteria, fungi, and antibiotic resistance genes. It is the initial paper where the bacteria, fungi, and but later on they have already added the viral pathogens also. Then then we have next slide, please. So this paper we have published. This is a rapid culture-free detection of carbapenem resistance Klebsiella pneumoniae in case of bloodstream infection using genomics. We have published in the IGMM, and where this is we are able to detect the Klebsiella pneumoniae, and also culture also came positive. That is also matching. Next slide. So the setup is very simple, and you can see a fungal adapter is there, and one fungal is there, and the minion sequencer. These three part actually are most important, and we have a genomic analyze software, and we have a computer and a sequencer. So sequencer we have three parts: fungal, adapter, fungal, and minion sequencer. This is the basically the sequencer, very small chips, and we have a data analyze software, and turnaround times we usually given 20, it can be done in 12 hours, but we have given 24 to 48 hours because samples will be coming from far away, and we have to do the extraction, then application library, and it is not that. So and direct from sample setup. So setup is very in a one single room, small room, we can do the sequencing part. Next slide, please. So this is the basic molecular setup requirements: single channel pipettes, 10 micron multi-channel pipette, filter tips, microfuse tubes, water bath, PCR normal thermal, conventional PCR, rotary mixture, magnetic bead stands, vortex mixture, cubate for reading the dsDNA a second, then centrifuge on site. So very small. It is not. It will be not costly like these small instruments. It will be not much costly except the Oxford Nanopore. Next slide, please. So this is the sequencing setup we have discussed. Small footprint, 1/10 of the capex of the sequencing. If you see in corrodes, the normal sequencing of thermopicture, easy to set up and easy to implement. Next slide, please. So this is the 16S and ITS region. So 16S were covering all the bacterial genomes, prokaryotic 70S ribosomes, eukaryotic 80S ribosomes. So it covers everything. So in prokaryotic you have say 50S and 30S, so 23S and 50 5S RNA, 34 proteins, whereas 16S RNA you have 21 proteins. Here, if you eukaryotic 16S, you have almost 45 proteins, and 40S, we have almost 30 proteins. So it covers all parts here. Next slide, please. So this is the ONT sequencing, and each DNA strand is pulled through the nanopore. Each base causes an electrical disturbances across the nanopore captured as a signal, and base calling performed. Next. So this is we take samples from different samples. We take blood, bone marrow, pericardial fluid, pleural fluid, intraoperative tissues, deep tissue abscess, tissue biopsy from bladder. We take from even directly from upper the suprapubic bladder, musculoskeletal joint fluid, intra abscess. Respiratory we have now limited to bowel sample only and pleural fluid. Not we have started ET aspirate or sputum aspirate or urine samples we have not tested, because then there will be a commensals, we have the interpretation will be little more difficult. Next slide, please. So this is basically our tournaments, sample collections, DNA extractions, pre-sequencing preparations, sequencing, data analysis, and report generations. So all takes is 12 to 24 hours time. So this is the normal clinical. So we have a TRF design. So everything, all clinical details they have to fill, and we have to analyze, because our interpretation part we have to analyze in details. So we need a complete patient's information here. Next slide, please. So we in Max hospitals, we have completely validated many samples, not only 15 samples. I think we have validated almost 3 to 6 months. 3 to 6 months validations, And we have done many samples, not only 15 samples, I think almost 40-50 samples we have validated. And we have tested as a patient testing, direct reporting, almost 72 samples we have already reported from July to September. Okay. So plasma, we have reported 17 samples and positive 17, negative 20 samples. Tissue 11 sample, 9 we have got positive, 2 are negatives. BAL 11 we have got positive, 0 negative. ET aspirate 2 because sometimes clinician force us to do, but we don't recommend. 1 negative, 1 positive. Synovial 2 for samples, 1 positive, sorry, 2 positive and 1 negative. Next slide, please. Acidic fluid 2 positives, 1 negative. POS 2 positive, 1 0 no negative. CSF 2 positive, 1 negative. And from viral transport media, because viral is also added in the panel, 4 positive and 0 negative. So the LEAP is basically it is a institutive medicine. Conditions are diagnosed by their symptoms. Treatment efficacy is uncertain, should be changed on a free of service basis. Empirical medicine focus on the pattern recognitions. Results can be predicted and caregiven follow-ups. But we have precision medicine, disease causes are understood, exact diagnosis and routine. So many things are helping in diagnosis. Yes. Now I'll go through some of the case studies, and this will be really helpful for you. How we have diagnosed very, very difficult cases by nanopore sequencing. Next slide, please. This is the current case of 59-year-old male patient with a past history of vocal cord polyps, tuberculosis, on splenectomy, hypertension, pacemaker, type 2 diabetes, so many comorbidities. He has chest pain and recurring fever, chills and sweating, shortness of breathing. He is diagnosed with aortic valve endocarditis, coronary artery disease, and degenerative valve disease. On CT scan, reveal a floppy mass over the aortic valve, and size is almost 11 to 12 mm size. Next. So all the blood culture comes sterile. Repeated blood culture was sterile. So they know the diagnosis, but which organ is they will not able to, because blood culture negative, already patient on antibiotics. So in endocarditis, it will be very difficult. So he had a surgical procedure done and the bypass graft, and they have sent the vegetation to us. Then patient was shifted to intensive care with mechanical ventilators, and they have started antibiotics. His vegetation sample was sent for culture. That was also come negative. The vegetation tissue also negative. Next slide. So on nanopore sequencing, we got ebiotropia defectia. It is basically our streptococcus vedans group and histoplasma capsulatum. And it is all sensitive. So I think we have given simple antibiotics, beta-lactam antibiotics, and histoplasma capsulatum. Initially, we have given amphotericin B followed by itaclozole. So endocarditis, what happened? The surgery is successful, but again the patient will relapse and have a lot of complications. So here, so diagnosis is even important because we have to give a 6 weeks complete treatment. So that's why endocarditis vegetation tissue got ebiotropia, exotropia, and histoplasma. Next slide. This is another case study. The current case of 70-year-old female patient with past history of chronic kidney disease, bronchial asthma, left ventricular failure, hypertension, type 2 diabetes. So many conditions. She has not associated with chest pain or palpitation or fever. On examination, she was tachypneic, tachycardia, and drowsy. A provisional diagnosis of type 2 respiratory failure was made, and the patient was initiated on regimen of Tazac and alongside supportive therapy. A gradual clinical deterioration of the patient ensured, and she had intubated and put on dialysis. The patient had a Foley's catheter, central line, endotracheal tube, right tube, so all invasive procedures. Patient developed features of sepsis on admissions. Next slide, please. The patient worsened to develop septic shock with meandering arterial pressures and resuscitation and diabetes level increase, vital white WBC count, raised calcitonin, mildly elevated levels of bilirubin, creatinine, BSI secondary, associated pneumonia, and suppressed blood pressure. Both the culture and nanopore sequencing group Klebsiella, with this we have published. The resistance is BLAS CTXM and 170 reads and BLAS CSSB 108 reads and NDM 597 reads. So we identified the resistance in nanopore sequencing and patient on septagenemic background as administered and patient polystyrene the following. Next slide. This is another study case, very important, interesting case. The current case, 72-year-old patient with a past history of hypertension, type 2 diabetes. He complained weakness in right side of body since afternoon on 27 July. He got operated left frontoparietal extradural abscess. He underwent drainage of abscess and went debridement on 27 July. He developed weakness on right side body of since then there is no history of loss of conscious vomiting. So basically weakness. So MRI brain can reveal an enhancing cystic cavity in right parietal is surrounded by the edema, enhancement and epidural regions and soft collections. He was operated in frontoparietal extradural abscess. He underwent drainage abscess. His pus and blood sample culture are sterile. Next slide, please. So all culture was negative, but his pus sample was sent for nanopore sequencing and nanoporans QT bacterium acne. So during procedure surgery, so some normal flora QT bacterium acne, NRV bacteria is centered, and that was giving infections and weakness. Next slide. So if you see diagnosing impact of Cutibacterium brain abscess, Cutibacterium acne, formerly known as Propionibacterium acne, is a gram-positive anaerobic bacteria associated with skin condition, particularly acne. However, it is present in brain abscess, though rare, holds a significant diagnostic importance. As a part of normal flora of the skin, Cutibacterium acne can be contaminated in clinical samples. When identified brain abscess, especially in patients with neurosurgical procedure, Cutibacterium acne should not be dismissed or mere contamination. Slow growing nature of Cutibacterium acne often necessitates a prolonged incubation period of cultures and identification lead to targeted antibiotic therapy. Recognition potential of Cutibacterium acne as a causative agent based on also an importance and clinical evaluation. Unless nanoparticles we are not able to diagnose these organisms. Next slide, please. There another case, the current case of 64-year-old female patient with past history of carcinoma, esophagus, hypertension, vocal cardiac palsies. So there is a shortness of breath, and desaturation, drowsiness, and poor intake, bilateral pneumonia, pleural effusion, tracheostomy done, sepsis, imaging and diagnosis of results. So this is a left ventricular hypertrophy, chest X-ray also. There is an interval of placement of right-sided chest drain with irrigation of left pleural effusion, blood culture sent to laboratory. Next. Culture sterile and IV steroid, IV antibiotics, IV PPI nebulations, culture showed sterile again, paired blood pressure sterile. Next. For nanopore sequencing, we got Enterobacterium PCOS. So you can see the resistance patterns. So we already know that it can cause endocarditis. So we have given treatment and patient successful. Next slide. Another important case study is chronic kidney patients, diabetes, hypertension, hypothyroidism. So all are predisposing factors. Breathing difficulty, shivering and fever from the last few days, chronic kidney disease, type 2 diabetes, hypertension, imaging diagnosed results, X-ray chest, right-sided central line in situ, CT thorax chest, mosaic attention on patchy area and air trapping in bilateral lungs. So next slide, please. So all cultures are sterile. So Shiva started many things, and the culture which is also against become sterile. Next slide. Next slide. Yeah. So on nanopore sequencing, we have grown Velionella, Parvula, and Streptococcus viridans, and this is the sensitivity patterns. So you can see fungal not detected, innervactive not detected. So you know all the details when we do a nanopore sequencing. How important in this case. Next slide. So these are the two organism details. It is a gram negative and some is gram positive. We'll can know the details. Next slide. So another, like I think last case, this is a current case, 61-year old patient with a past history of chronic kidney disease, diabetes, hypertension, cough, fever, and dullness. So endocarditis and severe mitral regurgitation moderate. So we have done the operations and the vegetation tissue sent to us. Next slide. Culture, no growth, and patient has started all these things. And again, culture also, the tissue culture also no growth. So all endocarditis cases with tissue and blood culture we got negative. Next slide. So on discussion, there is a preemptive knowledge of the organism and clinical relevant resistance genotype can aid in the appropriate antibiotic choice and institution of adequate infection control measures. Early alert of plasmid mediated carbapenem producing strain can help in hospital infection control and immediate measures to strict contact precautions and initiate the patient care ecosystem. We take a step further, identifying not only causative pathogens but also antibiotic resistance genes. So, if you should summarize, initially, sequencing NGS was a very difficult challenge for ID, infectious disease. But after development of nanopore sequencing, I think there are some lab has started, some hospital has started, and we are also getting a lot of benefit. But there are many things where to maybe it will take more time or standardization, many things which are lacking. But the way forward is that we have to go more on advanced technology, and nanopore sequencing is really helpful. It can detect many organisms, metagenomics, all the viral, bacteria, fungal, and anaerobic and aerobic bacteria together. So this is my experience which I have shared you, and that much. Thank you very much. These are all the references. This is thank you. So all the references. Next. Next. These are all the references. Next. I think yeah. Any now we have to move to question answer session.
Dr. Sadia Khan wants to know, how do we interpret multiple pathogen detection, especially when all are potentially pathogenic?
Right. So there are many clinical conditions we see, and we see the beads also. What is the exact ratio of beads? So this is happens mainly some samples where you will get multiple even ball samples or some of the samples uh, or like in the what I'll say some of the VTM media or some of places. But if you got multiple pathogens and there are true pathogens, we have to report in a proper sterile samples. Then again, our clinical discussions is very important. We have to discuss all the things with the clinicians. Then only we can start antibiotics. Like we have got 2 or 3 pathogens, sometimes 4 or 5 pathogens, but then we have to see, especially in ball sample, this is a challenge.
Dr. Sadia, I hope that answers your question. We have another question from Dr. Ajay. Which 16S region you target specifically to identify a pathogen?
I think Dr. Samile, you can answer this question.
Huh. Uh, Hello?
Yeah, you are audible.
Yes, yes. Um, the whole of the 16S RNA region is targeted in
Yes.
our sequencing test. I hope I'm
Right.
right, sir.
Yes.
Yes, okay. Any more questions? Any more questions?
So I think the more the study will be coming, more publication. There are few publications and few clinical changes has come. Once the things will be go incorporated to many clinicians, and then more queries and more questions will be coming. So these are few publications are now. I think more publication will come.
Any more questions?
I
Oh,
think there are no more questions.
oh, it means that they've understood everything about whatever you have said, sir. So,
Yes.
thank you so much, sir. Sir has used this particular innovation in solving not just cases in a scientific and clinical way. He has summarized concisely in how he has helped these patients as a doctor and bringing positive change in the patient community of Max Saket using infexn NGS from Haystack Analytics. We thank him for his proactive approach in embracing this innovation, and he is honing this and he is uh, improving this as he goes, and he's making a difference as a clinical microbiologist, and that is something we as a younger generation we should pick it up from sir, and we really thank him, and he is an inspiration, and these cases are a testament for his commitment towards clinical microbiology, and we are proud to be associated with sir. Thank you so much, sir. Um, I hope this
Thank
session has
you.
answered most of your queries, and if not, you can always get back to us. And we also have an upcoming webinar on drug resistant tuberculosis, which is moderated by our CEO, Dr. Anirvan Chatterjee, and an esteemed another speaker, just like Dr. Bansidhar, Dr. Rajendra Prasad. He is also the speaker of this particular drug resistant TB problem, and I hope you all manage to attend that as well and gain knowledge and become better clinical microbiologists, just like Dr. Bansidhar sir in our future. Thank you so much for attending and making this a wonderful session. Thank you all.
Thank you. Thank you.
Thank you, sir. Thank you.